my name is Brian Belva. I am a psychologist here in Louisville. I'm originally from Kentucky and did my graduate training at Louisiana State University. And then I've been in private practice here for about 6 years. I specialize in psychoeducational evaluation. So the most common referrals would be for ADHD, autism spectrum disorders, as well as learning disorders. So, dyslexia, dysgraphia, dyscalculia. Now I wanted to talk a bit about, what are the common components of a psychoeducational evaluation. So I know some of this was in the previous presentation, but the reports typically follow, this layout. So the beginning of the report will have a few pages about background information, and I know we went into a lot of detail in the first presentation about kind of what's asked of the parent. And then we have a list of the tests and measures that were given. So this is kind of to quickly be able to look at what all was given for the assessment, and it's basically just a list of what all was administered. And then we have the testing data section that has more all the different tests and what the scores were for the child. And then the summary and diagnosis, where we summarize the report and what diagnoses were given. And then the final part is recommendation section. This is the most common method. Sometimes you may get a report that looks a little bit different though. There is a medical model sometimes that people will follow. So you may get a report where it gives the referral information and then it immediately goes to the summary and diagnosis. So, at some places, at a more medical clinic, you may see the layout of the report look a little bit different. But I would say for the most part, this is probably what to expect when you get a report and kind of what the contents of it would be. The first section is the background information section. Like I said, it typically is a page or two in length. Sometimes I will have a parent that will ask, I want a part of this section removed, or I don't want it shared with the school. I may give you some examples. So let's say maybe there's a family history of alcohol abuse in the family, and that's something that, they wanted removed and they don't want that shared, with other providers or with the school, because that's more confidential. And, that's something that I will remove if it doesn't really impact the diagnosis or the child. So you may sometimes see a comment in the report that, a certain section was removed to protect confidentiality. The list of test and measure section is, like I said, a really, kind of a one-page or a half a page list, but it can be used to kind of quickly look at what tests were given. And like I've mentioned before, we definitely, there are some tests where we don't want to re-administer them in a certain time frame. So, I know that at school sometimes school providers will administer some testing, or here at the Langsford Center, do a lot of testing for children for reading, that we may be able to use a different version of that if we know that something has already been administered to a child recently to avoid any practice effects. I'm going to go into a lot more detail about these final three parts of the report in the next slide. So, especially here, this testing data section, I want to talk about what all's in that section of the report and kind of help you all understand more of the contents of it. Let's see. So, commonly in a psychological evaluation or a psychoeducational evaluation, we have an IQ test or a cognitive test. The most common ones would be, these are referred to as the Weschler Test. So several of you have probably heard of that term or maybe have even administered some of these tests. But the WIPC is what we would refer to that one as, the WISC or the WACE. And so the WIPC, typically would be for a child 6 and under. A WISC would be for a child 6 to 16 years old, and then a WACE would be for 16 and up. We do have a little bit of wiggle room sometimes with these tests. So, if I have a 6-year-old, they could be given the WIPC or the WES. So there is some overlap And we make that call based on, if I'm seeing a 6-year-old and we're concerned about an intellectual disability, we would probably give the WIPC because it kind of has, a lower floor. Whereas, we may give the WISC for other 6-year-olds depending on what the referral question is. There are other IQ tests, so you may see like the Stanford-Binet is one. This is referred to commonly as the DAS, or Differential Ability Scales. Woodcock-Johnson has a IQ test. I know a lot of times school providers may have heard of that one. The academic test seems to be a little more popular, but it does have a cognitive battery as well. And then, these are common components of an IQ test. So I'm kind of making it very broad, kind of sweeping, but I'd say that the 4 common areas of an IQ test oftentimes are kind of more verbal reasoning, nonverbal reasoning, working memory, which working memory is kind of more short-term memory and kind of abilities to solve problems with memory, and then processing speed. So those are oftentimes 4 common areas on an IQ test. So I wanted to talk in more detail about each of those areas and kind of what they entail. So the first area, they'll talk about is more the verbal reasoning. So the verbal reasoning kind of is, I'm going to talk more about the WISC, which we talked about how it's for kids from 6 to 16. But the verbal comprehension is kind of measures a child's ability to access and apply acquired word knowledge. And specifically, the score reflects one's ability to verbalize meaningful concepts, think about verbal information, and express oneself using words. So these are some common, subtests that we would look at for verbal reasoning skills on an IQ test. So, vocabulary, we'll just go through, so for example, what does the word naive mean? And, the child would need to define different words and kind of see their vocabulary abilities. Similarity, so like how are green and blue similar? They're both colors, obviously that kind of get progressively harder as it goes on, but this is kind of looking, a bit more at abstract reasoning of verbal skills. Information, so kind of that's more rote information about the verbal reasoning skills. And then comprehension, so like, what do you do if you find an envelope that has a stamp on it? What would you do with that? Definitely there can be certain profiles for verbal reasoning. So, certain areas, especially like the similarities area and the comprehension area, a child that has an autism spectrum disorder may have a little bit more trouble in those areas because they're a little bit more of an abstract verbal reasoning ability. So definitely when we do an IQ test, we look at the full scale, or a lot of times people think of their main full scale IQ score, but we're also looking at, the different areas within the IQ test as well. I wanted to talk a bit about nonverbal reasoning too. So, these are some different kind of common nonverbal reasoning subtests. So, on the WISC, it's split up into 2 different areas. So visual spatial areas and then fluid reasoning areas. So, for the visual spatial areas, that would be looking at a child's ability to evaluate visual details and understand visual spatial relationships. Some of it involves constructing a geometric designs from a model. And definitely the visual spatial area measures visual spatial reasoning, integration, synthesis of part-whole relationships, attentiveness to detail, and use of hand-eye coordination. So this first one here, would be a block design subtest. So, on this one here, the student is given 3-dimensional blocks, and then they're asked to recreate this design that's a 2-dimensional design. And so that would, be a visual spatial task that we would have the child do. This one here is the visual puzzles. So they're, the child looks at this, this design here at the top, and they're asked, what 3 pieces would make the design from down here that would make this design. So, kind of this one here, this one, and this one would comprise or form that design there. And then fluid reasoning abilities are also part of nonverbal kind of testing as well. The word fluid kind of looking more at novel tasks or new tasks for the child. The fluid reasoning index measures, kind of underlying concept relationship among visual objects and use of reasoning to identify and apply rules. And then identification and application of conceptual relationships requires inductive and quantitative reasoning, broad visual intelligence, simultaneous processing, and abstract thinking. So this one would be kind of a pattern recognition, so kind of what would come next in the pattern, and kind of nonverbal reasoning skills. And then this one here, the figure weight, this is kind of, again, a nonverbal task where, it's showing that 2 blue stars weigh the same as 2 yellow squares, and then it's saying 1 blue star, what would it weigh the same as? So the 1 yellow square. So kind of, these are common tasks that we'd be doing in that nonverbal reasoning domain. Working memory is another area, that we look at. So, and you guys may already be familiar with a lot of these subtests, but the digit span is oftentimes one that kids really dread because it can get kind of hard for the kid. But we would say the numbers 2, 1, 4. Now say them backwards. So 4, 1, 2. And it's difficult. But then when it gets up to 5 or 6 numbers, it can get to be a really difficult task. And so working memory is short-term memory, but also kind of that ability to kind of work out problems in your head and kind of use that information you're remembering to kind of solve problems. The picture span subtest is also a part of the working memory index. So on this one, a child is shown 2 different designs, and then they're asked to show what order they saw them in. So they would touch, that they saw this one first and then this one second. So they're having to remember, this one is more of a visual working memory, whereas the one I mentioned before is more auditory, hearing the numbers. And then processing speed is also, a common area that we look at for the IQ test. So processing speed would measure speed and accuracy of visual identification, decision making, and decision implementation. Performance is related to visual scanning, visual discrimination, short-term visual memory, and visual motor coordination and concentration. On this one, on the coding subtest, the child is, each number corresponds to a different symbol, and then they have to quickly draw the symbol that corresponds to that number. So, this is not really, looking at how quickly they read or how quickly they do math problems, but more kind of overall cognitive speed. How quickly can they work on a more rote kind of task? And then the symbol search, is also a processing speed area. So on this one, that one's over there in the right-hand corner. So, there's 2 symbols on the left, and then they're asked, is one of those 2 symbols on the right side? And then, if it is, mark it. If not, mark the no. And how many can you do quickly in a 2-minute period? Processing speed abilities, I know sometimes as school coordinators, you may have children that get extended time or get, extra time on testing. It's common that, we have a child that may have, their scores all look pretty strong, but then they have a low processing speed score. So that would kind of indicate that they, they benefit from more time to be able to solve problems. And they can do really well, but when that time component is introduced, it's harder for them. These 2 areas are oftentimes impacted in ADHD. So when we look at an IQ test, it is very common, not always, but for an IQ test to have, these 2 areas be a little bit lower in a child with ADHD versus the verbal and nonverbal areas and some of the other areas that we talked about. This is kind of a common graph that may be on a report. So if you guys as a school professionals get a copy of this report, this could be a common graph that you could see. And I kind of wanted to talk through, what does all these numbers mean? A lot of times when I, go over this with parents, I'll say, a lot of times when people talk about IQ scores, they'll talk about, like an overall IQ score or my IQ is this number. And we talk about how, if you want to go about that one number, a lot of times you're looking at this full scale IQ score, and especially this composite, or sometimes it'll be referred to as a standard score. But then I like to emphasize that, we don't always want to put a ton of weight on that overall score, because, kids can have variability in different areas, and, sometimes that one score is not always the best depiction of cognitive ability. So, we go through these different areas, which we just kind of did in the previous slides. On this one, as you can see, the working memory score is kind of popping out as a lower score, which could be kind of indicative of, an ADHD diagnosis, or even, a child that may be experiencing some anxiety and having some trouble with memory abilities. So, some of these other columns, the percentile rank, that would be, again, these tests are comparing a child to other kids their age. So, if this was a 7-year-old, we would say, this is based on other 7-year-olds. So on the verbal comprehension area, the child had a percentile rank of 70. So that means that they performed better than 70% of other 7-year-olds on a national sample. So a lot of times that's how I'll word what that column means. The confidence interval is just saying that, if we were to re-administer this component to the child again with 95% confidence, we would believe that that score should fall within that range. And then the qualifying descriptors, are more kind of using standard deviation. So if we're, again, looking at this bell curve here, a 100 would be, an average score for a 7-year-old. And then on the Weschler scales, it has a standard deviation of 10. So meaning, these lines here would say between 90 and 110, 2/3 of kids would fall in that range, which would be considered the average range. So 90 to 110, and then if we have scores that are lower or higher than that range, then the child would be falling outside of, that average range. And, most of the time I do include those qualifying descriptors. There are some times where I may not use them, as much, and kind of, because it all kind of depends on what we're using them for. We definitely don't want to label a child, but also, we are comparing them to other 7-year-olds their age. So that was kind of more about the IQ test. Also for academic testing, I know with the Langsford Center, I know probably y'all are already well versed in a lot of these tests, but we also will give academic testing as part of a psychoeducational battery. We may not always give all of this stuff. We can definitely tailor it. If a child we're more concerned about their math abilities, we may dig really deep in the math stuff and then do more, just a few in some of the other areas. So we likely won't do all these things, but we may if needed. The most common one, would probably be the Wyatt. So that is also a Weschler scale. So it's, the Wyatt 4, but also the Kaufman, the Woodcock-Johnson is a very common academic battery, and there are several others as well. And so, these are some of the common areas. Most of the academic batteries, mainly reading, math, and writing, are the 3 main areas on it. And then we go deeper into each of those areas. So, with reading, we will be doing word reading and reading comprehension, reading fluency, which that word fluency just means reading speed, kind of phonemic awareness or phonic abilities, and then the math and writing are also broken down into different sub areas as part of it. All right, let's see. Let's see here. And then it looks like, on here, let's see, I think that my slide's off a little bit. Let's see. So kind of talking about, the table on the left, talked about some of the IQ scores. This one here is kind of more like what a chart would look like for academic scores. So again, using these standard scores that we talked about from before and kind of comparing them to, these percentile ranks as well. So, a lot of these have, if you're using the Wyatt, that is a Weschler scale, kind of with 90 to 110 being in the average range. And again, the percentile rank that we talked about before. I did want to talk a bit about, I don't think this presentation obviously is not about, diagnosing learning disorders, but I did want to kind of touch on that. There are two kind of common methods to diagnosing a learning disorder. And the one that kind of we're talking about here is more of a discrepancy model. So, we talked a bit about the IQ scores and looking at those, and a lot of times we're comparing those IQ scores to how they're doing academically on this test. So, as a general rule, if a child is a good, 2 standard deviations or 1.5 standard deviations behind their IQ score, that they could qualify for a learning disorder. So that would translate to, maybe about 20 standard score points or composite score points roughly. So, if we had a child with an IQ score of a 100 and then they're achieving academic scores that are 80 or lower in multiple areas of an academic domain, that they may qualify for a learning disorder in a particular academic area. There can be some differences, with a public school system, they have very set criteria that they use. So, you can get on the Kentucky Department of Education website and see, some of the discrepancy tables that the state of Kentucky would use. And we definitely try to make sure to use those tests that the state of Kentucky prefers so that, if a child did qualify for a learning disorder, it can easily be translated into an IEP and that we're using the criteria that the state prefers. And obviously with children in a private school, we're not bound by some of those regulations. And so, those are, can look a little bit different. But with public school kids, we try to use the test that the Department of Education prefers for that. And then, another way to diagnose learning disorders would be response to intervention, which is, a lot different than, some of these areas where a child is kind of going through tiers of intervention, tier 1 where it's kind of more first line intervention and then it kind of being stepped up to kind of diagnose a learning disorder. So there's 2 different styles, but this style that we're talking about, definitely is more the discrepancy model for looking at a learning disorder. And I did want to talk a little bit about kind of confusion. I think sometimes there can be some confusion about a learning disorder versus an intellectual disability or a cognitive diagnosis, and that can create some confusion. A learning disorder, like we said, is where there is a discrepancy between a child's cognitive abilities and where they're performing academically. So there's that discrepancy where that they're not lining up with where they are cognitively. If we went back to that slide with the IQ scores, if a child was performing, lower cognitively, but those scores were commensurate with their academic abilities, then that wouldn't be a learning disorder. So, if we had a child that maybe had IQ scores that were in the 80s, and then their academic scores are also in the 80s, that's not going to be dyslexia. We're going to be, kind of looking at other things for that child. And I think that can be very confusing. And I know for parents, when I, meet to talk about results, that can be confusing because a child is, struggling in school, but they're not meeting criteria for a learning disorder, which can be confusing. But wanted to make that point as well. I also wanted to talk a bit about, so we talked about cognitive testing as well as academic testing. I wanted to talk a bit about, some of the testing we may do for ADHD or attention kind of based testing. And then I think a lot of times people hear the word executive functioning. That's something that, a term that's commonly thrown around. So executive functioning skills are things like planning ahead or being organized or memory or different abilities that are kind of higher order abilities that are oftentimes in the frontal lobes that can be a little bit harder for kids with ADHD. So we do, some different testing like that as part of the evaluation. This test here on the right that's, in the kind of the circle here. I'm sure a lot of you have probably seen this test before, but it is known as the Stroop Task, or it's part of the DCAF's test of executive functioning, but the child is kind of required to say the color of the ink, which is a harder task than reading the word. So, when we look at words, we want to just say, if we look at this word here, we want to read it as red because that's what it's spelled as. But we're asking the child to say the color of the ink. So they're having to suppress their natural instinct to read the word and instead say the color of the ink, which is looking, measuring attention and inhibition abilities. This is another one that sometimes we give. So this is known as the Tower subtest, or also known as the Tower of London subtest. But on this one, this child, would have to move disc on these 3 different poles to recreate a design that we give them. And there's different rules to it where a larger disc needs to be below a smaller disc. And it involves kind of planning out. So, some children will just jump into it and not think about the correct solution. But other people will, kind of want to be able to plan out the disc and kind of where they're located. So, this is a test of planning ability that's an executive functioning task. We also will do the CPT, so the CPT or the KCPT, that's one that's on the computer that we do. So on this one, and this is one that a lot of times kids really I tend to do it at the very end because it can be difficult for kids to get through. But it is one where, different letters are popping up on the screen and the child is having to quickly push a space bar. And if they see the letter X, they're supposed to not push the space bar. And it's looking at how well they can focus. And it goes on for, a good 7 to 8 minutes. The KCPT is kind of the younger version of it where they're toys that are popping up. And then if there's a soccer ball, they're supposed to not push the button. So again, it's looking at its sustained attention and focusing. And then this NEPSI, is a measure, and the NEPSI has, if you did the whole NEPSI, it would take 5 or 6 hours to do. But a lot of times we'll pull out different subtests that are related to attention. One I commonly give with really young kiddos, it's called the statue subtest. So on this one, I'm doing some really distracting things with the kid, and the kid is required to stand against a wall and keep their eyes closed and not move any, are kind of the rules to it. And then I'll do things like knock on the table and drop a pencil and different things. And it kind of goes through and has you record, is the child keeping their eyes closed? Are they not responding? Are they not talking? And kind of, again, is more of an observational measure of attention or hyperactivity as well, kind of abilities. And there's other measures as too for ADHD as well, but those are, some of the bigger ones, I would say. And then, on the testing, you'll see likely some emotional-based testing as well. For kids that are 7 and under, I typically won't have a child fill out a questionnaire that asks about emotional symptoms. So, but for kids 8 and older, typically that will be, an old enough age where a child can self-report some of the symptoms possible of depression or anxiety. And so we will go through a measure like that. So sometimes I will read the items to the child and have them respond and ask follow-up questions, or I may have the child fill it out independently for me. So the CDI would be the child depression inventory. The MASC is an anxiety inventory, as well as the RCMAS that we commonly use. And then we also sometimes will do more testing that's more broad. So these last two, the MMPIA or the PIA, these are both, or PAI, I'm sorry, these are both psychopathology inventories or kind of personality inventories for adolescents that kind of dig into a lot of different symptoms. So they have questions about bipolar disorder or depression or anxiety or OCD, eating disorders, drug and use type symptoms, and even early psychosis signs. So they're really broad measures. We don't always give those, but if we have a teenager where we're concerned about some of those areas, we'll give those. And the good thing about those is they have a lot of validity items to them. So, and what I mean by validity is that they have questions in them that are also getting at, is the teenager being truthful with us? Or, maybe a teenager may come in and want to portray themselves a certain way, or may want to look a certain way. So these measures kind of pick up on some of that stuff. And they also have adult versions of them too, but these are the teenager versions. And so we won't always give those tests, because if it's more just looking at a learning disorder or ADHD, we don't need to do something bigger like that. But if we have a case where we want to dig a little deeper, we will give a measure like that. And then sometimes we will do more validity testing. So, the TOM is a test of memory malingering. So the word malingering just means, someone, or effort-based testing where, is the teenager putting forth their best effort, or they may be not putting forth their best effort. So this can be a way to ensure that, as part of our testing, we're getting good effort from the teen and they're not purposefully trying to not do well in order to get a certain diagnosis. So these are tests that sometimes we'll give as well, but these are mostly for older teenagers that we would be giving. And then, talking about autism spectrum testing, and I know this could be a whole nother talk just in and of itself, but the ADOS-2 is probably the most common test for autism, and it's here to the right here. So as you can see, it can be a pain to lug around. There's a lot of objects that are part of it. They can get lost and destroyed, so it can be a lot to it. But there's actually 5 different versions of the ADOS that can depend on how old the child is and the child's verbal abilities that we would give. But some of these different tasks will be looking at obviously social abilities and any repetitive or restricted behaviors. So some of the tasks for a younger child would involve we would be playing with some of these toys and seeing how well they are they interested in involving the examiner in play, or are they very to themselves with their play. We do different things like I'll blow up a balloon and then let it fly around the room, and then see how does the child bring the balloon to me to want me to blow it up again? Do they look me in the eye? Do they have eye contact? We'll look at things like joint attention, like do they if I look in a certain direction and say look, do they follow my gaze? A lot of these are more for younger children, but also for older children or teenagers. We wouldn't be using all these little kid toys, but there are other activities that are more for older children that look at social skills that are part of the autism testing. So, definitely for autism testing, we rely heavily on parent report of symptoms, but we also want to have an observational component where we're seeing some of these symptoms during session, and if they're present during the ADOS. After you administer the ADOS, there's kind of almost like a rubric where we will rate what we saw during the ADOS based on some of the different activities we did, and there's kind of a cutoff score for autism that we look at. This is another common social kind of recognition task that we'll do. Again, I know we saw this earlier with the NEPC, but this is one of the social areas. So, look at this girl's face, and can you pick which girl which child feels the most like this girl? So it's kind of looking at facial recognition, which we know kids with autism tend to have more trouble reading facial expressions, and kind of that can be a task that we'll do to look at autism spectrum. There's also one called the theory of mind subtest that we'll give. So that subtest is kind of looking at different social vignettes and kind of what is the child's interpretation of that social vignette. And again, these tests are normed. If we give it on a 7-year-old, comparing their performance to other kids their age. Let's see. And then, we also have parent and teacher report measures. So I'm sure, those of you in the audience that are school administrators, have seen these measures, and we're also always extremely appreciative of the teachers that are willing to complete these. And then we also have parent measures. So, a lot of times the parents fill out a questionnaire while they're in the office with their child. And so they'll fill that out and give that to me. Oftentimes I will give either a BASC or a CBCL. And these two are very broad measures that have a whole lot of questions about different areas. So the child's learning and the child's attention, as well as things like social skills and emotional abilities. So it kind of asks broadly. So I typically always give a parent a measure like that because it covers a lot of different areas and can give a lot of great data. And then we may also give additional ones. So the Connors 3 is more of an ADHD measure. So, it can be common to give the BASC, but then also give the Connors 3 if we're concerned about ADHD, to have, that more specific ADHD measure. Some of these other ones, so the GARS is a more autism measure, and then we've already talked about the CDI and MASC. Those would be parent versions of depression inventories or anxiety inventories. And then similar to the teacher, I'm sure that you all in the audience have seen these measures. So they are teacher versions of the parent versions that we have parents complete. And it's always extremely helpful for teachers to fill those out, and even for certain diagnoses. So like for ADHD, we want to know that it's occurring both at home and at school. If it's only occurring at home and not at school, then is there some environmental factor at home, and then they're not displaying attention or hyperactivity or different things at school. That can help us to really make sure that we're diagnosing correctly and that we're getting that information. Let's see. And then, I wanted to also talk about, I know there are several school professionals in the audience, wanted to talk a bit about what's helpful for us to know for the child, before they come in for testing. I know a lot of times it can be hard to have a lot of communication, but if we do have communication, that can help us to best tailor the evaluation for the child. So, definitely we want to know what concerns the school professional has about the child, or has, what areas. So, if they're academic concerns, or a certain academic area, it's great to know, we're really concerned about John's reading, or we're really concerned about his writing. That can help us to really zero in, okay, I want to really go deep into that area as part of the evaluation. Definitely like focusing or attention, if we're concerned about the child's social abilities, to let us know that, or any emotional symptoms. And we talked, earlier about how we may not always do all areas as part of the evaluation. So, if we have that information from you, definitely we will make sure to, target that area as part of the testing, and then we may leave out other areas. And this obviously, helps, like I talked about with insurance. So, for some parents, some parents may just pay a copay for testing, or some parents may be paying into their deductible. So if we can, eliminate some units of testing that aren't needed, that can save parents some money that would go towards their deductible, that we can make it a lower cost for them. Also, it's great to have, grades or work samples. If a child does have a 504 plan or a student accommodation plan, for us to have a copy of that. A lot of times we can get that, from the parent, but if the school is able to send that to us, that can be very, very helpful as well. Or we may get a release from the parent and then request that from the school. And then I already hit on the teacher forms, and I'm sure for some teachers that are out there, I'm sure that those can be a pain to fill out sometimes, and I'm sure maybe they come at the most inopportune times where you're already, busy with a ton of things, and then you get an email about doing it, and we totally understand that. And but also, if you are able to fill those out, those are always extremely helpful, and we're very appreciative. And like I said, they very much help us with diagnosing, and because like I always say, we're spending 2 or 3 hours or 3 or 4 hours with the kid. But you're spending every day of the week, with the kids. So you're seeing a lot more stuff and have a lot of great input on that child. And so we love to get those. And then also, on the questionnaires, a lot of times there is like a a part where the teacher can write in comments. And I always love it when teachers, if they have information they want to include that maybe a question didn't provide, those are always very helpful, and love it when we receive that. And then, it can be great if if you are a learning coordinator and know that your child, you have a student that's going to be getting testing, if you want to go ahead and complete that authorization form to be able to speak with me, then that can kind of speed things up to where we already have that in place and we can communicate more quickly to best help the child. So I think that, would be a really helpful. And then some of the stuff we talked about earlier, I think really promoting parents to have their child be well rested and be ready for the evaluation date. As a school coordinator, if you can work with the teacher, if there is certain things that we're going to be due that day or certain assignments to best help that process. I think more so for like a teenager, they may be stressed that they had to miss that school day or that there's a test or something, to kind of best work with that student to make the evaluation day go as smoothly as possible. Awesome. Well, that was kind of all the information from this talk. I'm happy if anyone does have a question, they're welcome to unmute their mic or to speak up and ask a question for me to address. Awesome. Well, I enjoyed being with you all today. And like I said, this is my contact email, so feel free to email me if you have questions about testing. I'd be happy to speak with anyone, or if you have anything further about what I talked about today, that you have more questions or want more information, I'd be happy to speak with anyone. So, all right. Well, thank you very much.